We would like to welcome Professor Abbas Zaher. He is a very well-known international figure. He is a professor of orthodontics from Alexandria University in Egypt. And I've met him maybe for the past 10 to 15 years, and he's a very well-known figure. He's, as a professor, he's also the president of the Egyptian Orthodontic Society. He is the past vice president of the World Federation of Orthodontics, and he's represented the area in the World of Federation of Orthodontics for 10 years. And I think he did a very great job to put the Middle East and Africa on the map. He's also a founding member of the Arab Orthodontic Society, and he's been working with us and with other colleagues for the last 20 years. And I think he did a very good impact in that field. So I'd like to welcome him to give his presentation. Please note that you can ask questions in the chat, and we will ask Professor Abbas about the questions when he finishes his presentation. So I'd like to welcome Professor Abbas, and the mic is yours.
Thank you, dear Akram. It's a pleasure to be with the Iraqi Orthodontic Society members, and the invitation is an honor for me. And let me share my screen. One second. Okay. It's a great honor to be invited to give a lecture to the Iraqi Orthodontic Society, and a pleasure for me to meet you all. And by the way, Dr. Akram have made a very nice webinar with the Egyptian Orthodontic Society a few weeks ago, and one of the best webinars that we had over the last period. Of course, everybody was busy with webinars since the COVID-19 have erupted, and it was as a side effect, was a good opportunity to listen to very good lectures from all over the world. I hope I can do as good of a job as he did for the Egyptian Orthodontic Society members. So as you can see, my topic will talk about the orthodontist contribution in dental aesthetics. We have to remember always that we are a part of the dental team, and all modern dentistry depends on a team, not on a single operator. But I want to emphasize for you that we need to work interdisciplinary rather than multidisciplinary. Because when I looked at multidisciplinary treatment planning in the Webster dictionary, this definition came out, which is a group of healthcare workers working together of different disciplines independently, treat various issues a patient may have, and focusing on the issues in which they specialize. So they work each in his field and independently. However, interdisciplinary definition was a group of healthcare professionals from diverse fields who work in a coordinated fashion toward a common goal for the patient. So that's the difference between multidisciplinary and interdisciplinary. We are always working with other disciplines in the dental field, but the difference is interdisciplinary, we work in cooperation. We don't do our job and then shoot the patient to the next operator. First, because we are talking about aesthetics, let's agree on the characteristics of an aesthetic smile. Akram, I'm trying to remove the photos from which cover part of my screen. How can I do that? 1 second, I'm trying. Anyway, that's fine. So first of all, we have to agree about the characteristics of a good aesthetic smile. The level of the gingival margin of the two of the two central incisors. I lost my okay. We're okay now, Akram?
Yeah, now it's okay. And there's no pictures anymore.
No, I have still the...
We can't see, we're only seeing the screen.
Okay. Now I removed my picture.
Okay.
Okay. So now it's fine. So we would like to have the level of the gingival margin of the two central incisors at the same level, and a little bit higher than the level of the gingival margin of the lateral incisors, and then at the same level or a little bit higher on the canines. That's the gingival margin level. We also like to have the incisal edges of the two centrals level, same level together, and a little bit longer by 0.5 millimeter than the level of the two centrals, and forming a consonant smile meaning a smile curvature that is conforming with the lower lip contour upon smile. We would like to have a small incisal embrasure, not too big. And then this incisal embrasure will be increasing in size as we go backward. So between the central and lateral will be larger than between the two centrals, and then even larger between the lateral and the canine. And that's because the contouring of the distal part of the teeth. Then a good thing is to have a long contact made of enamel, which constitute about 50% of the contact between the two centrals, decreasing to 40% between central and lateral, and then 30% between lateral and canine. The contour of the gingival margin is conforming with the axial inclination of the teeth. So normally, we'd like to have the maximum deepest part of the deepest part of the curve of the scallop line inclined slightly distal on the incisors, conforming with the axial inclination. Again, the contact area should be an area rather than a point, constituting half of the crown at the middle and incisal third. We have to have a small incisal papilla, small incisal embrasure, and a gingival embrasure filled with a healthy papilla, completely filled with healthy papilla. We would not like having a space or a black triangle in this. So in interdisciplinary treatment, we always have to remember that we work with brackets and wires. So we have to remember that they don't have to solve all the problems. We have to exploit other specialists for the ultimate benefit of the patient. So the main goal should be the ultimate benefit of the patient, not doing our job with the tools that we have or we master. So it depends on us to communicate and cooperate with other dental specialists. And minding what does the dentist or the other operator need and what are the needs of your patient. So the operator or the other specialist, he wants us to facilitate his future work, his complementary work. He wants us to give him accessibility in order to be able to do good preparations, to furnish good restorations, and to give him a case that is giving him the possibility to achieve the best outcome. And as far for the patient, of course, the patient wants the best aesthetics outcome. He wants the easiest procedure. He doesn't want to go to other doctors too many times and waste his time. And he wants the cheapest price to pay. So if we can cater to all these needs, then we would have been doing a good interdisciplinary treatment. So what can the orthodontist do? And which aspect can he contribute to the orthodontic, to the ultimate dental aesthetics? I chose two areas to speak about in this presentation. And we have almost like 6 or 7 areas that we can help in producing the best aesthetics. So we can help in the preparation for restorative work, and we can have good consideration of the aesthetics during our treatment. Of course, when you look at this kind of, I don't want to call them buildings, but this kind of buildings, as a non-engineer, I would assume that these are buildings built after a design by an engineer and constructed by an engineer and so on. However, they look so ugly and so poorly done. At the same way, the patient, they know that they don't know the word orthodontics as much as they know that the word braces. So a lot of patients, they say, I need braces. They don't say, I need orthodontics. So if this doctor gives them braces, they believe they are having orthodontic treatment. So we can see this kind of patients who are maltreated by dentists, and the patients feel that are having orthodontic treatment just because they have brace. And this kind of treatment or poor orthodontics is usually caused by faulty diagnosis. So if we don't know what the cause and what the problem is, if you cannot visualize the problem, then we will not be able to do a good treatment. If you do not do a plan or you do a wrong planning, then probably you will not achieve any improvement. And then if you don't have the tools and you don't have the knowledge to execute the plan, definitely you will have bad outcome. But most probably it is caused by all of the above. And I found this picture over the internet, which shows a good example of a very poorly done, and how can a poorly done orthodontic treatment cause a disaster. So we're going to start about the preparation for restorative work. And for me, ideally, I would love to have the work done before I do the orthodontic treatment. So before we start any interdisciplinary treatment, we have, if we see the patient first, you have to do a good diagnosis and then identify the needs of the patient, and then consult or refer the patient with the other specialists that can help, in your opinion. Let them examine the patient, prepare their own planning, and then together we sit and we design a comprehensive treatment plan. We discuss the detail of the plan with the patient, including steps, including the cost and the time. The patient has to know all this in advance. And finally, we can then make the stages of the treatment. So who will do first, what we'll do first, like restorative first in some cases, or orthodontic treatment preparation first in other cases, and then we execute the treatment. This is an example of a 16-year-old patient who came and didn't like it, was not liking his smile. And if you look closely, you will find that he has a difficult case or orthodontic case, +3 case, crowding, anterior open bite, and then the most difficult situation is this geminated central incisor, and the other one is missing and it is impacted. So crowding, class 3, anterior open bite, geminated centrals, and the palatally located left lateral incisor. So from the X-ray, to see what's going on, from the canine to the molars, it's clear. Let's look at the front area, which is the more complicated area. So this lateral incisor is already erupted in its position. This left lateral incisor is the one that is palatally located, root and crown actually. And then this geminated left central incisor is this one. And this impacted geminated also right central incisor is impacted here. So now we have an understanding of what are the problems in hand. So I used all my previous dental knowledge and decided that I'm gonna extract one of the geminated teeth and keep one at the end of treatment to make on it a bridge or a crown that has two smaller central incisors. And in order to help the treatment plan, I wanted to extract one lower central incisor to correct the crowding in the lower. It will also help in the closing of the open bite, and it will help also in the created Bolton discrepancy when I fabricate two smaller central incisors instead of two normal size central incisors in the upper. So I thought it was a win-win situation, and I went ahead to do this. So we're gonna take out two teeth, two central incisors. In the lower arch, we'll close the spaces to align the teeth, relieve the crowding, and close the open bite. And in the upper play, I will have this lateral take the position of the central incisor, geminated central incisor, and then expose the one impacted and bring it in. But this patient cannot go around after the extraction with space of the two central, without two central incisors. He will be very upset and it won't look nice at all. So I decided to make this tooth, artificial tooth, on a transpalatal arch that would be placed temporarily until we bring the left lateral incisor into occlusion and align the teeth, and then I would expose the impacted central incisors and pull it into its place. So until he has the lateral incisor come out into the place of here to come out in this place, then I would remove this artificial tooth and start bringing the impacted central incisor. So I placed this artificial tooth here, fixed with the pans on the upper first molar on the transpalatal arch, and that's how it looked. And then I used it to align the teeth to help in the anchorage and alignment of the teeth. If you can see here, the bracket on the lateral incisor, I don't know if you can see or not, but this bracket is reversed. You can see the dot here, which should be positioned upward and distal, is located mesial and downward. So the bracket is reversed. This way, it will induce an automatic reverse torque of the root of the center of the lateral incisor once I put a rectangular arch wire. So after alignment, I'm using the central replacement here for alignment. And then when I placed a rectangular arch wire, this to start torquing of the root to upright it. At this moment, I decided that I can remove the transpalatal arch with the artificial tooth and expose the impacted central incisor. So we did exposure, etching normal. I wound the bracket, and then I attach an auxiliary flexible arch wire to the bracket in order to pull it into occlusion. Normal way everybody does the impaction of teeth. So after it was coming in smoothly, and the lower arch meanwhile was being aligned, the space is closed. I placed some triangular elastic to increase the anchorage against the upward pull on the incisors and canine. This bracket is still reversed to induce torquing on the root, because the root was totally in the palate. Until I have the tooth in position, now I have to centralize it and send it to the restorative dentist to fabricate his crown. So at this moment, this is how I finish the case. And I send the patient to a very good prosthodontist to do the crown that I had in my mind. So the prosthodontist, first one, he declined to do the treatment, mainly because he told me that it's a very difficult case and the patient will never be satisfied, and he will never be able to get a good, acceptable result. Why? Because that's how I send it to finish the case. So everything made very good sense for me at the beginning, but now when I talk with the dentist, in my mind I had an idea that he will do a crown that has two central incisors like this, and everything will look great. But first of all, he explained to me that the boundaries of his crown has to be the neck of the tooth. So he has to finish his finish line on this narrow neck, and it's not possible to do two good central incisors the way I had in mind. So the only way two central incisors can fit in one crown is to do like this. So you respect the small neck of the tooth, and then the crown has to be narrow from the incisor, from the gingival. And then another problem is the difficulty in fabricating an gingival embryo. So in brief, the first dentist, who was my first choice, he declined to do this case. And the patient was disappointed because in his mind, I did a big mistake after so much, I don't know, a year and a half of treatment or 2 years. And he was not very satisfied that the dentist decided not to do the crown. So anyway, I sent him to another dentist, and he accepted the compromise, and he did this crown. It's not excellent, but I think he saved the situation. And I don't think till now there is another option for treatment of this case. And anyway, the patient was satisfied. And this is an example of a multidisciplinary treatment plan. And that's why, because I decided the treatment plan on my own, I didn't consult first, underline the word first, with the other specialist and see his needs. Maybe he would have done the same, but at least he would save me the embarrassment of sending the patient to one and the doctor tell him it's not feasible, and I don't know what he told him about the orthodontic treatment plan, but it was better for the patient to know who will continue the treatment and what will be done, how much, and what's the time frame. So this is an example of a multidisciplinary treatment plan that I did, which I consider a mistake at that time. Let's look at this patient. It's also an interdisciplinary treatment planning. The patient has many malocclusion. She has axial inclination defect in the incisors. The rotation of the canines are not similar, so it gives the impression that one canine is wider than the other. The lengths of the teeth are not equal, so the two central are not equal. The laterals is maybe longer than one central, although the incisal edges are aligned, but everything else is not aligned. Gingival margin level is not well aligned. As we said, we wanted to have this level, the two central at the same level and higher than the lateral. So it's different, it's not well aligned. So taking into consideration what we need to do, I talked with her prosthodontist and with her, and we decided that she will have 4 veneers or crowns on the 4 incisors after treatment to align the incisal edges after I aligned the axial inclination and the gingival margin level. So she knows in advance her restorative dentist expect her to do the crowns after treatment, expect to from me to align the gingival margin and the axial inclination, and he will correct the incisal edges. So everything is clear for me, for the patient, and for the other doctor. We know exactly who and what will be done. So I place the brackets, not at the based on the incisal edges, but based on the gingival margin level. So when I have a straight arch wire, the gingival margin level has improved a lot. Now I need to place some bends in the wire to micro-align the teeth. So some bending in the wire, tip back the teeth, intrude the centrals a little bit. Then I find out that I need to intrude the 4 incisors to align the gingival margin better with that of the canine. I don't mind about the over bite because this will be corrected by the dentist. So I place another wire, I intrude with it the 4 incisors, and that's how the case has been ready for the restoration of the incisors. At that moment, I send the patient to the restorative dentist to see if he has a comment on the position of the teeth before I deband. Once he gave me the green light, I debanded the case, and the case looked like this. So if you finish a case like this without having an agreement with the patient that she will have to have crowns, then she will think that you failed your treatment. And if you send her to another doctor, it seems like you're sending her to another doctor to correct your mistake. So but if you have planned and told her and explained to her exactly how she will end the treatment, now she knows that you are a good dentist. And then the restorative dentist made his crowns and the case looked beautiful. And that's an example of interdisciplinary treatment, because I saw the patient, took my time, diagnosis, and with x-rays and photos, discuss it with the restorative dentist, and then we agreed on a treatment. And then I explained to the patient exactly how she will end up, the steps of treatment, that she knows the cause, and she knows who will fix her teeth after the treatment. Then that's a good example of interdisciplinary. Before and after smile, big difference. That's before. The gingival margin levels were misaligned. At the end of treatment, they became well aligned. So that was my job. aligned the axial inclination and the gingival margin levels. And then the restorative dentist took care of the defected incisal edges and the shape of the teeth. Another case that was a big guy, big in size, I mean, but he had severe attrition of the incisors. As you can see, reverse arc of smile, unequal size of teeth, spacing, and small incisor, and also the midline. Let's first talk about the gingival margin. The gingival margin was malaligned, so the central is the same level as the laterals, and the canine is even shorter, and then the difference in the size of the center. Length of the teeth, of course, because of the attrition, is unequal. The midline was shifted toward the left side. So taking into consideration all of this, I did also the width of the incisors, the central incisor compared to that of the lateral was small. So the width was like 4 to 5 instead of 3 to 4, 2 to 3. So we need to increase the size of the central incisors. So I make my planning. I selected the size of the central incisors to increase by 1.5 millimeters each central incisor to improve the ratio between length and width and the ratio between central incisor and the lateral incisor. Also, I wanted to have the midline corresponding with that of the face here. So I'm going to bring this tooth in the middle of the space here and bring this tooth in the middle of the space here. And increase the size of the central incisor by 1.5 millimeters. And then after that, the laterals will keep the same size and the canine same size. So having in mind this, I start, that's what the proportion that I want to, 3 to 4, and 2 to 3 lateral to central incisor, and 2 to 3 canine, the part that's showing of the canine to the lateral incisor. This is the golden proportions that we need to reach. So again, I place the brackets according to the level of the gingival margin, not to the incisal edge. So you can see here that this bracket is almost at the incisal edge. So once we have a straight alignment with straight arch wire, we have improved the level of the gingival margin of the incisors and canine. We still have the spaces. We have this left central in the middle of the space that will be increased. So we have here midline. He will increase a little bit on the expense of the mesial and a little bit on the expense of the distal. The other central incisor as well will have spaces mesial and distal to increase the size. That's how the case was finished and sent to the restorative dentist. Finally, he did his restoration, the crowns. And if you see that the original plan was followed almost to the millimeter. And again, this is an example of interdisciplinary treatment plan. Because I discussed with the other orthodontist, I discussed and explained to the patient beforehand, and then I did my part and referred to the orthodontist according to his plan to do his part. Every time before I deband, I send the patient to the restorative dentist to give me his final okay. So accordingly, we have to decide, when do we do the restorative interference? When do we request restorative interference? When we do an interdisciplinary treatment plan. Do I ask the restorative dentist to do his restoration first, or should I do first my orthodontic treatment and send him the patient to do the treatment? I want you to know what are the advantages of having the restorative treatment first. First of all, it will give you an idea of the true shape and size of the crown, because you are working with crowns. I know you are minding the root angulation and everything, but what you see every time the patient comes is the crown of the tooth. So if you have a proper crown with the proper size, it guides you to place the tooth in the proper position without thinking too much. So that's an advantage for the orthodontist. Give you a realistic representation of the tooth angulation. So if the provisional restoration is done according to the tooth, to the axial inclination of the tooth, then it gives you a realistic representation. Sometimes there is what we call a column angle, and the crown angle is different than the root angle. Finally, for the benefit of the patient, if he has a defected tooth or a missing place or a place of the tooth, he enjoys a good aesthetic during the course of the treatment. He doesn't have to wait until he finishes the treatment in order to get his final aesthetics. But again, everything has disadvantages and advantages. The disadvantages are sometimes it's impossible to do your restoration before orthodontic preparation due to space and accessibility problem. There is a hindrance in the doctor cannot prepare or cannot fabricate a crown or on the tooth unless you provide him with space and accessibility. If the tooth is located in an impossible place to be corrected, then it's impossible for him to do a good job. The patient, most of the time, will have to do a provisional restoration and then repeat the restoration after the orthodontic treatment, do the permanent restoration. So that's an extra expenses and time on the part of the patient. So patient has to understand this very well. So in this case, you can, of course, imagine that the restorative interference could be done before, during, or after orthodontic treatment. So when to choose what? As I said, I want to have the restoration done before treatment so that I can visualize the tooth true size and shape and inclination of the tooth during treatment. Easier for me, and the patient will benefit of good aesthetic during treatment. Example of this case, the patient has a missing right lateral incisor and this peg-shaped left lateral incisor. Patient have space and possibility to fabricate a composite or crown on the lateral incisor before we start the treatment. Took an X-ray, and that's what I was talking about. The axial inclination of the root is different than that of the crown. So I send it to the restorative dentist, asking him to do a crown with the golden proportion so that I have a good proportion between the lateral and central incisors, to do to make it according to the axial inclination of the root, not the visible crown, so that I can finish the case well. So that's what he did. Crown with the axial inclination of the root, good size relative to the central incisor. So for my work, I can do my work, finish, and close the spaces here, and then measure this crown and keep a space, another space for the missing lateral incisor here for future implant. So that was facilitating greatly my work. The tooth looks good during treatment, not have to wait after treatment. It is very difficult to align, to adjust the peg-shaped lateral during treatment as vis-a-vis the contact, the axial inclination, and so on. So a lot of advantage for this patient and for me. Then finally, the patient had a space on the right side similar to this space so that he can have a crown, an implant and the crown at the same size. Of course, as we said, there are limitations, which is mainly space and accessibility. Because in such cases, we have to prepare or to do some preparation, some orthodontic preparation before sending the patient for restoration. This patient had 2 small lateral incisors. So I did alignment, open up extra space on the distal side, as you can see, and then remove the bracket on the lateral incisor, send it to the restorative dentist to restore the lateral incisor, then place back my brackets on the lateral and finish the spaces. So he did his restoration. The size is good. He had extra spaces on the distal side, so he did his restoration and finished all the aspect of the crown. I think it was a composite crown very well. And then when he sent the patient back, I was able to place the bracket and finish the teeth well. If you see here, I kept all the space in the distal aspect. Why not? Why I didn't keep the tooth in the middle of the space? That was the recommendation of the restorative dentist. So it's a good idea to send the case to the restorative dentist, asking him where he wants the tooth to be placed, mesiodistally, labiolingually, and vertically. He asked me to place the contact, to have a good contact mesial, and leave all the space distal. And that's why, because we know that the mesial incisor angle is usually right angle of the lateral incisor, and the distal line angle is a curve that needs a little bit more of space. So that's what we did, and that's his restoration, exactly conforming to the planning he has done. Very good idea to send the patient before your debanding to the restorative dentist for final okay. Another case, there is no space for the restoration of the lateral, which are small. Here is peg lateral, very small lateral, and then the broken incisal angle will prevent me to make a good contact, because there is no, it invaded the contact area. It's not going to be easy to make the contact. So I start by aligning, relieving the crowding. Once I have this initial alignment, I can remove some braces and send it to the restorative dentist to do his restoration. So he did 2 composite crown and this incisal angle. So this will give me a good idea of the spaces. I have a good idea of the crown shape. I place back my bracket and do the final touches and finish the case. Another one more example. The overlap that is existing here created, and because of the broken contact and incisal angle. So I did sectional arches. I retracted the canine until I open up enough space. Then I align, initial alignment, and send the patient for restoration of this angle. I needed the restoration of the angle in order to be able to do a good contact. So he did a temporary restoration with composite, and he told me that he will do a final restoration after final alignment. After that, I was able to adjust the contact well and finish the case, and then send it for a final composite restoration, or I don't remember, maybe crown. Last case, it has a broken distal angle here. I also open up spaces, extra spaces, did the restoration of the distal angle, and then close the extra spaces until we finish the case. So restoration done during the treatment is very useful to finish well the case. But sometimes we cannot, it's not advisable to do the restoration during treatment, and it's better to wait at the end of treatment, such as when we don't need the restorations for the orthodontic finishing. If I don't need it and it's not disfiguring for the patient, then I would postpone it to after treatment so that the patient doesn't waste some more time going back and forth to the dentist. He doesn't spend more money doing temporary restoration that will be redone after the treatment. So if I don't need them, I don't ask unless the patient really asks for it. And when there is major dental work that will be done, there is no point of doing part of it and then redoing the rest again afterwards. So in these cases, we do our restoration after the orthodontic treatment. Again, we have to agree with the restorative dentist and the patient beforehand that you will need such and such restoration. Lost incisal angle is not very disfiguring, is not encroaching on the contact, so I don't need it for orthodontic purpose. The patient doesn't need it for aesthetic purpose that much. So it could be done after the treatment and it will look perfect like this, and it's done only one time. This case is different. The patient came, she was complaining of two crowns that were fabricated, very large crown, to close some of the spaces between the incisors. The central incisor is too large. In addition, she has extra diastema, space in the diastema. So the large crown was bothering her. The proportion between the central and lateral were skewed. So instead of 2/3 the lateral, 2/3 the central, it's 2 to 5 the lateral incisors, and then the width to length was almost 1 to 1 instead of 3 to 4. So these things need to be arranged, and the patient wanted a quick and local treatment. She doesn't want to do everything. She just wants to close the spaces, give her a situation where she can do other good-sized crowns on the front teeth. So again, we did smile design. So we need to intrude the incisors in order to be able to close the spaces. We need to decrease the size of the crown of the central incisors in order to conform with the golden proportion. So we need to decrease it by a millimeter, 2 millimeters, I think. And then she will have to have crowns on the 6 front teeth to improve the size, the canine shape, and the 2 centers. So if we do the restoration first and remove these crowns before we start the treatment, then she will have extra spaces in hand, and that will be disfiguring for the patient. So we decided that we start closing the spaces during treatment and reduce the crown size mesodistally as we go. So every time we close the spaces, we reduce the spaces, we can decrease the size of this 2 central until we reach the size acceptable for the restoration. So we close the spaces and we reduce the crown. You can see here, we reduce the crowns of the central incisor quite a bit. Intruded also the incisors. So now she finished. She has 2 crowns that are smaller in size. She will have spaces because she will have to do another crown. And we intruded incisors, so the overjet is okay. And then she will have six teeth to be complete. So the restoration will be 6 front teeth, canine to canine. Each crown is separate, good size, and successful multidisciplinary. So the proportions are good, and no spaces. Of course, the smile is much, much better. Of course, cases of cleft, when you have to do a lot of movement, and then finally you will have to have a bridge, the case cannot be done during treatment or after, because you cannot fix the segment. So we do our treatment, expansion, alignment, and so on until we have the gap. And you know that the oral hygiene sometimes in these cases are not so great, and we have to compromise our treatment in order to conserve as much as we can the tissues. So in this case, the treatment was compromised. The crown, I know there is midline shift, and he had to fabricate a new canine. So this one is a canine, another canine lateral incisor that were missing, and then the 2 centers. So this is an example that this case has to be done, restorative treatment has to be done after, because it's a bridge that will fix the part together. This final case, she has bimaxillary protrusion, she has crowding, broken up incisor edges, anterior open bite. So we decided that she will need, I'll do an alignment, reduce the protrusion, correct the open bite, but she will need to correct the shape of the 4 incisors, 4 top incisors with crowns. We decided with her restorative dentist that I will correct the alignment, axial inclination, open bite, protrusion, and then he will have to fabricate 4 crowns on the incisors in order to correct the incisal edges attrition here and here. And most importantly, this anticipated black triangle. I anticipated that the papilla is lost and it will not be possible to correct. She didn't mind those, but the top one was very visible. So when I finished the case like this, she was not astonished. She knew that she will have to finish the 4 incisor with restoration. And that's how she was finished. She was very happy with the difference that was done before treatment, after treatment, orthodontic treatment, and then after the restorative treatment was good result. So from this part, I want you to remember that we need to do interdisciplinary treatment, as I explained, and not multidisciplinary. We have to diagnose, consult, discuss with the patient and doctor, and then have the patient consent to the treatment plan. Make sure that you consult first, then start your treatment. Don't start your treatment without consultation with the specialist. Early restoration will give you a better feel of the size and shape of the crowns, so they can treat the case easier. But the patient has to be aware that restoration done before and in the middle of treatment might need to be redone. So that's an extra expense and extra time. Sometimes at the end of treatment, some small grinding or enameloplasty would improve the case another 50%. So in this case, I finished alignment and everything is orthodontically correct. Then I look at the attrition in the incisal edges, and I decide to do some minor enameloplasty to correct the attrition. And minor grinding has made a big difference for this case, as you can see. Sometimes we need to do more enamel grinding, especially in cases where there is more attrition of the incisal edges. And sometimes you have to do you can do more reduction in the enamel, but keep in mind that we want to keep the gingival margin relationship well, the high, the canine, low in the lateral, high in the central. So the high, low, high that we all hear about, we have to keep it. And we want to keep the relationship of the incisal edges where we have the two centers longer than the lateral incisor, so we can have the curve of spine. So I can mark here that I need to grind here a little bit, corner and here, to give good final incisor edges. I know this is a little bit short, but this is the most conservative grinding I would do for the patient to keep the gingival margin at the same level and the incisal edge a little bit longer than the lateral incisor. That's before and after the grind. Sometimes we do grinding to give illusion, different illusion, like we know that rounded corners give the illusion that the shape is smaller than the sharp corners. If you look at this one, looks smaller than this one. However, they are exactly the same. I'm going to show you an example of this. This case came to me after finishing treatment by a couple of years. And the patient and her mother, they came to complain that the two central, they moved forward and they are too much showing. I know that they were aligned well and there was no problem in the alignment, but the problem is the shape of the distal line angle, which was right. So I suggested that we do a little grinding of the corners of the central incisor. So I mark them with a black marker like this. And then I round them, and really the teeth look smaller after alignment, after grinding. So just roundation of the corner by maybe 0.5 millimeter, but it looks smaller, and really the patient was satisfied. This other patient, from the start, I can see that the corner, the distal corner of the lateral incisor is very sharp, and the lateral incisor look even very large compared to the center. So I know that I will do some grinding and roundation of the corner like this after the treatment, and I told her in advance. So that's before after treatment, before grinding here, the corners, and that's after grinding, much better. Sometimes we resort to more grinding or enameloplasty after treatment because this is an adult patient which has axial inclination problem, and the teeth has been subjected to attrition according to their position. So after alignment, then you can see that there is attrition here more than the distal, and the patient needed some grinding. So after grinding, which it took me like 5 minutes, the end result really looked much better than before. So this is before grinding, and that's after grinding. And the amount of grinding, if you see, is not too much. That's the amount of grinding, this excess in the incisal edge here and here, little bit on the lateral incisor. Other case, because of the difference in the axial inclination in the central incisor, the incisal edges has been subjected to attrition and are leveled now. But we know that after we correct the axial inclination, like we did here, you see this embrasure, it's closed here because the two teeth has, we have distal tipping on them. So we close the embrasure, but what shows now is the V-shaped or the small attrition that are more apparent because it was more in the mesial than the distal. So a little bit of correction of this, and the result show another 50% improvement of the smile, and the amount of reduction in the enamel is a little bit more than the first case. So the 4 teeth needed some reduction here. Finally, this case that needs a lot of reduction because the attrition that was excessive here, the incisors are too long, lateral have been subjected to attrition. So once we align, we can see that the incisal edges are not aligned at all. So we did some enameloplasty, and that's the amount of enameloplasty of reduction that we did in this case. So from here to here, another really a good amount of improvement. And you have to remember that when you remove from the incisal edge, a thicker part of the crown appear at the incisor, at the level of the incisal edge, because the tooth is conical in shape. And when you reduce from the incisal edge, you go into a wider part in the from the occlusal, from when you look from the occlusal. So you have to reduce also from the palatal aspect. When you reduce from here, you have to reduce from the palatal aspect in order to have a thin incisal edge. And these are the burrs that I use. This wheel burr is to level the incisal edge. These two are for reduction of the palatal aspect to make the incisal edge thin. This finishing burr for the roundation of the incisal edges, and this one is a white albine burr to finish the enamel and the polishing using Soflex disc. I think by now we have we did enough. I think we have exhausted my time, and thank you for your kind attention. And